Estás a punto de mirar una entrevista muy importante. La doctora Dr. Jennifer Mercier es una figura reconocida globalmente por su trabajo como médico de fertilidad y también por su trabajo como partera. Entonces, ojalá que tomes el tiempo para mirar la entrevista completa. Gracias Liliana en Colombia por ayudarnos con la traducción. Es un grandísimo trabajo y estoy muy contenta de poder ofrecer esta entrevista al mundo hispanohablante justamente porque es información tan importante y ella tiene una perspectiva muy distinta. Entonces, disfruta mucho la entrevista y nos vemos en los comentarios. Gracias, bye bye. Good afternoon with the Yo Soy Pachamista YouTube channel. Today I have the pleasure of speaking with Dr. Jennifer Mercier. Dr. Jennifer is an icon in the women's health space. She's a midwife, a naturopathic doctor, a filmmaker, an author, and really an icon in the women's health space in fertility, working with women who have scar tissue issues. There is so much we need to cover today, particularly about fertility. I want to cover quite a bit. I want to give you a chance before we begin to introduce yourself a little bit and tell us how you became this world-renowned practitioner in the women's health space, because I know that it was probably a long journey to get to where you are now. So let's start out by having you tell us a little bit about who you are as a woman and the steps that you took to become who you are today and teaching what you teach today.
Thanks for having me, Katie. I'm Dr. Jenny Mercier. I really have a passion for healing and teaching and just educating women about what their body is capable of. And that started back in my early 20s when I was diagnosed with stage 4 endometriosis. I learned a lot at that point, and I was a clinician for the Center for Human Reproduction, and I saw what kind of failures we were experiencing with medically assisted cycles, and had no idea back then really what I was seeing so much in detail. But I just noticed that when it came time to do pregnancy tests after IVF cycles, that many women weren't pregnant, and there was a lot that went into those cycles. And so I worked in the clinic for a year, and I really learned, like that language, how to speak the language of medical reproductive endocrinology, infertility. And then fast forward years later, when I had trained as a massage therapist and did a training in bodywork for the childbearing year with Kate Jordan, and learned that doulas and midwives were a thing. And I'm like, oh, wow, that sounds amazing. I have to be a doula. So I trained to be a doula. I trained with two organizations, Dona and Alice, and I was a doula for maybe a year, maybe a year and a half. Most of the births I attended were in the hospital, and I just found them to be really invaded upon. It was hard to attend, hard to watch, recognizing, that nursing staff, and God bless them, they don't have a lot of time with each patient. So these women were kind of left to their own defenses. And then here I am trying to support them and being viewed as an invader in the nurses space. And I didn't like that feeling. So I'm like, okay, well, I have to be the midwife. I have to train to be a midwife. And I did. And I trained in Summertown, Tennessee at the farm with Ina Mae Gaskin and Pamela Hunt and Joanne Santana, Deborah Flowers, and also with the Miami Beach Maternity Center, Sherry Daniels Rosenbaum, and I also trained at the border of El Paso and Juarez, Mexico, at the Casa de Nacimiento Birth Center, which is now non-existent. The other birth center was Maternidad La Luz, and that's the one I started to say, but that's not the one I was at. I'd visited that one. It's quite beautiful, and it is still there. But then, training in naturopathic medicine, I did a dual ND PhD program, and I'd always wanted to be a doctor. Trained undergrad to go to med school, and never did that. But through all of that training, I also had stage 4 endometriosis myself and Hashimoto's thyroid disease, and in learning how to take care of myself, I really didn't do it well. I relied on medicine. I was on an oral contraceptive that would knock me flat on my face every month with pain. Other than endometriosis pain, I would have terrible headaches and weight gain, and just didn't feel myself, lots of depression. And then suppressing my thyroid with medication to protect it from antibodies, egregiously rapturing it. When I found a more natural way, when I found a better way, I was able to manage with manipulation, physical manipulation of my organs by way of just me kind of poking around in my own pelvis and pushing past pain patterns. And I thought, oh gosh, this is really helping me. It's really helping me. So I'm going to incorporate it into practice, which I did. Practice was small back then. I was just starting out, and midwifing and then naturopathic practice combined. But the naturopathic side of the practice was still being built, where I had plenty of midwife clients. But the women that were coming in, I'd say, come on in. If you have pelvic pain, come in, come see me. I'd be working with them for pelvic pain. And then these women that were told that they couldn't get pregnant were getting pregnant. They were getting pregnant. I'm like, okay, I guess this is something to expect. I don't know. As I kept working, this kept happening. And I decided I would do a study. So I did a study, and I didn't have that many women in my study. It's like 44 women, but out of the 44 women that I was caring for, 83% of them got pregnant. And these women were told that they weren't going to get pregnant. Real quick aside, I just wrote a new research abstract study, and there's 200 plus women in that study, and the success rate's 86%, 86.4%. So I've submitted my research to publication, and they're reviewing it currently, but if it gets published, that will be huge. So yeah, this work has just been nothing straight of a blessing. I treat women of pretty much all ages, from adolescent, teens, women of childbearing years, women that are perimenopause, postmenopause, and beyond, for pelvic pain, pregnancy, cesarean section recovery, gynecologic surgical recovery. And it just keeps surprising me, Katie.
So that's something I forgot to mention in your intro, that you have trained so many practitioners in what's called Mercier therapy, and that is manual manipulation. I don't know if manipulation is the right word, but manual movement with your hands or practitioners' hands of the uterus and other organs in the abdomen. And that is so important, because modern medicine has totally lost the art of touch. We have totally lost the art of touch. For most of human history, touch was an absolute key component as a diagnostic tool, not as a diagnostic tool, and then also as a therapeutic tool. And we've completely lost that art. So would you say that manual manipulation, and correct me if that's not the right word, but would you say that manual manipulation is appropriate in almost all the clients that you see? Is that like one of the main things that you do when someone comes in? Because I realize that there's hormone analyses, there's supplement, there's food, dietary, everything. But is that kind of where you would start with somebody who comes to see you?
Absolutely. Absolutely. Mercier therapy is deep pelvic visceral manipulation. So you're right with the term manipulation. We literally are manipulating the uterus, the ovaries, the tubes, all of the surrounding structures to improve upon mobility and restore blood flow, which overall optimizes function. So yeah, this is key work. And when you say that, yeah, it's a lost art where, providers, doctors, even mid-level providers like nurse practitioners and physician assistants have lost the art of touching a person to examine them, because we've gone to things like telemed, or we've gone to other modalities where we're not actually sitting down with patients where we're just doing an interview over a Zoom or a Google call, you know? And so when women come in to see me and I tell them, you know, hey, I'm going to need to touch your thyroid. Is that okay? Yeah. So I'll go ahead and do a manual thyroid exam, and they'll say, well, no one's ever done that for me before. And I'll say, oh my gosh, that's a key component to fertility. And in the last, I would say, maybe 4 months, I've found two aggressive tumors on women that otherwise never would have been found if nobody put their hand on these women's necks. One of them actually, she's like, yeah, I've got cancer. And I'm like, okay, all right. So thyroid cancer is very slow growing. And then she calls me, she goes, I don't know what to do. And I said, well, let's get the opinion. Let's see what they want to do to treat this for you. They may just want to take out the piece of your thyroid or your whole thyroid or whatever it is. And she called me the next week and she goes, and I'm pregnant now. And I'm like, and I treated her. That's what I treated her for. But when I initially saw her, I did a thyroid exam and I said, you need an ultrasound. Let's get an ultrasound and see what's going on. And here it is. But now she's pregnant. So they're going to wait to do anything with the thyroid. Another gal, I said, I really don't feel, sometimes I use my spidey sense, you know, kind of like, this is not feeling right to me. I need you to have this checked pretty soon. Like, I need you to do this. And she did. She went and checked, and she's got a suspicious nodule as well. So how can we skip over putting our hands on people and missing these things that could be egregious in the future? It's just not the way I operate. I'm always, no matter what, church or even at the grocery store, I'm touching people's arms or hugging them or whatever. I just think that's such a lost thing. We need to do that. It's a connection, right?
Absolutely. I think it's a lost art in the world of practitioners, and then it's a lost art for ourselves. Like, we should be touching our thyroid. We should be massaging our breasts. We should be touching our uterus. Like, it's so your body craves to be touched.
Right. You're so right. I saw you. I'm like, I touched their thyroid and I saw you doing this. I'm like, oh, there she goes.
Good reminder. I do feel like my organs really appreciate when I acknowledge them.
Yeah. Isn't it true? Because the thyroid is the thermostat and metabolic regulator of your body. And if it is not tuned up correctly, that's good enough birth control for the body. And it's such an interest. Isn't that interesting?
Time.
So we have to not skip over things. We've got to put every puzzle piece back where it belongs. And if we're not doing that, we're doing a great disservice to whoever we're serving.
Mm-hmm. Yeah. So yes, absolutely. And then just actually seeing the patient, right? Like, let me see, what do your eyes look like? Are they clear? What does your tongue look like? What is your demeanor? What is your, just
Right.
seeing the person.
Right. Cracked coated tongue. I mean, okay, what's going on here? What's your nutrition like? Yeah, I mean, it's like a whole head to toe evaluation. And then I congregate here with my work in the pelvis. But yeah, I don't leave any stone unturned. It's important not to do that.
So and I realized that so many people, as you mentioned, many women of many different life stages come to see you. Ideally, they would come when they're adolescents so that they can avoid so much of the maybe kind of the pain and trauma we go through in our 20s when we still don't understand our bodies and our cycles, etc. But I want to focus on the woman who comes to your practice who has received the diagnosis of unexplained infertility. Where would you begin with a woman who comes with that? Maybe you might even start with questioning the word infertility.
Right. Well, so what I would do is they'd come in for a consult. They'd get a full medical, gynecologic, and obstetric history. And if they've done any sort of medically assisted cycles, we get all of that down. And then I would want a full panel of cycle day 3 labs. to look at what the egg reserve looks like and see what the female hormones are looking like at the beginning of the cycle while she's bleeding. And then a full thyroid panel. All of that can be done at one time. Oh, prolactin as well. Prolactin hormone is responsible for making breast milk. And if a woman is not nursing a baby, her prolactin should not be elevated. If it is elevated, it tells me that she's potentially and very likely not having ovulation cycles. And a lot of doctors miss that too. I'll see a woman and then I'll do these labs and I'll be like, oh, wow, your prolactin level is very, very high. You're probably not having ovulation cycles, just to find out that she's got maybe a pituitary adenoma or needs medication to reduce the burden so that she can ovulate. But it's so multifaceted with this unexplained, which is about 60% of the cases of fertility. If it's unexplained and there's no pathology like endometriosis, polycystic ovarian syndrome, adenomyosis, polyps, fibroids, then we have to look a little deeper and say, okay, do we need to correct something here in your diet? Do you need to stop smoking tobacco, THC? How many COVID shots did you take? You know what I mean? Like, right. COVID has a clotting component. Is your blood running too thick? What's the cause? And I just try to go into every single facet that I can think of. And again, I pull from the spidey sense a lot and I think our intuition can guide us and take us a long way when trying to figure out what's going on with somebody.
So the initial labs that you would order on day 3 would be AMH.
AMH, FSH. So AMH can be run any time of the cycle.
Okay.
You could do that any time of the cycle. Day 3 labs are FSH, estradiol, progesterone. I would add in a fasting prolactin level, testosterone, and DHEA. And the last two, testosterone and DHEA, are usually not a day 3 lab, but I do it because I think it's imperative to know if she has cystic masses or she has some sort of physical signs of polycystic ovaries or polycystic ovarian syndrome. Like if she has lengthier cycles or she's got, male balding pattern, or she's got a 5 o'clock shadow here, or her upper body habitus is heavier. And I can just tell if I need to do DHEA testosterone levels, because if those are elevated, she's probably PCO, maybe PCOS, and not having a natural ovulatory cycle.
Mm-hmm.
So those are the labs that I would do.
And progesterone also on day 3, I guess it'll be low. It'll be really low, but okay. It's
low. So estradiol, progesterone have to be low on day 3 to signify that you're bleeding, because both of those levels drop to allow you to bleed. But if either of those remain high on day 3, that tells us that there's an issue maybe with testosterone converting inappropriately, or there's a diminution ovarian reserve. So it does tell us what we need to, a couple of key factors, what we need to know on day 3.
Okay. And then, so once you get the blood panels back, then you would move forward with that client and go ahead and start the visceral manipulation. You would go ahead and start the pelvic work as well.
I don't need those labs to start the work. I would, to get the ball rolling. And sometimes if a woman has a provider already in place, like an OBG or a PA or NP, CNM, even a PCP, they can go ahead and have those labs drawn with their provider. So it's covered by insurance. Does not matter to me who does the labs, as long as they can get done. Or they'll come in equipped with their labs saying, I've been to the reproductive endocrinologist and here's my labs, and I'll take a look at those labs. As long as they're done within 6 months, the last 6 months of coming in, I'm good with that.
What are your thoughts on AMH? Because I know some women who might get a lower than desired AMH level and think that that their destiny is written in the stars, that they just don't have enough ovarian reserve and they can't get pregnant. And I have heard that it's very possible that that number can go up.
Yeah. So standard guidelines, AMH is 2 to 4. That would be great. Those are great numbers, 2 to 4. Anything above 4 can suggest cystic ovaries. Anything below 2, you're starting to think about a diminishing reserve. Anything below 1, you're thinking a real diminishing reserve. But you know what, Katie? I've had women come in with undetectable AMH who've been told that they need to have donor eggs and they get pregnant. We can't force a woman that has low AMH to go through something like IVF because they will be a poor responder. Every study says so. You can't make a woman have more eggs than she already has. If she has 2 eggs left and you're trying to force her to have 15 eggs to do an egg retrieval for IVF, you may get some what I call dummy eggs. They're not real, or dummy follicles. They're just not real. And they'll go in and retrieve them. There'll be no eggs in there. They may get one good egg from an IVF, an IVF cycle, and then that one good egg goes to the embryologist and they perform ICSI, intracytoplasmic sperm injection, where the embryologist chooses the sperm that he or she wants to force into the egg. And then the egg, because it's older and it's not of good quality, may become an embryo for a minute, and then it fizzles out very quickly. So we are not to use force with women like that. And unfortunately, it's being used every day. They use too much force for women that are not good candidates for IVF. And it's a problem. Now, here's my take on IVF. There are medically indicated cases that need IVF. I have a couple that I'm working with currently. He had testicular cancer when he was young, and he doesn't ejaculate any normal living sperm. He has none. It's called azospermia. So they have to go in and do a testicular extraction of sperm. That's a big deal. So IVF then would be the correct choice of medicine for them. For others that are just forcing the cycle every single month with IVF, they're really doing their body a great disservice. I mean, when you have that many eggs that you're trying to hone in on and make viable for retrieval, your estrogen can be in the thousands, and it typically is. Our bodies are used to 150 to 300 per dominant follicle, per one follicle. When you've got clusters of follicles on either ovary, on both ovaries, your estradiol levels are in the thousands. And then you go in and you get retrieved, and that level drops very quickly. That's putting your body, your ovarian and your breast tissue at a higher risk for breast cancer, ovarian cancer, endometrial cancer. So if you need to do IVF, get prepared to do IVF. If you have a tubal occlusion, or you've had an ectopic and you've had your tube removed, or you've had some sort of surgery that is preventing you from having a natural conception, let's weigh out the factors and make sure that you're a good candidate for IVF, because in the IVF world, you are a good candidate for IVF all the time, because it's $20,000 per IVF cycle. So, and I used to work in this industry, so I'm telling you, I've seen this, and this was back in the early 90s. It's still the same today. It's no different.
Yeah, it is. Unfortunately, so many of us we're now older, and so many women are older and realize maybe in their late 30s, even early 40s, like, oh wait, I do want to have a baby, and potentially might assume that, oh well, like no matter what, I'll be safe because I have this IVF option. And I think it was actually in one of your videos, you were talking about the success rate might be as low as 25% or something, like 20 to 30.
That's for women that have a good egg reserve.
Oh my gosh. Yeah. But
Yeah,
yeah,
it's in the lower teens for women that have the worst of egg reserve. And you can find that data at SART, SART.org. That's the Society of Assisted Reproductive Technology.org. And they show you all of the data from all of the participating clinics in the United States. So you can go there and see the numbers yourself.
wow.
It just is.
Those numbers are really low, which makes the numbers that you discussed in the two studies that you've done, the 83% and then 86.4%, those numbers are even more astonishing because that's IVF is very, very far from having an 83% success rate.
Very far. Very far. And again, like, I'll be very honest with the women, with the couples that I work with, about what might be a good option for them. And if it's IVF, I'm going to tell you. If it's an ovulation induction cycle, I'm going to tell you. If it's doing nothing except doing the work that I'm doing, I'm going to tell you. And some women sit in front of me and they're like, no IVF. It's almost like that's what they had their heart set on. They had their heart set on doing IVF. And when I tell them no, and then they go do it, and then they come back to me after they fail IVF, they're like, yeah, you did tell me that. And by then they've had many, many eggs retrieved, maybe a few embryos made, maybe they've done a few frozen embryo transfers at that point, and nothing has come to fruition. And it's very sad because putting a couple through that is intensely challenging. And I do believe that IVF decouples the couple, because now you're taking a man and a woman and treating them as patients separately, and you're not, allowing for conception to occur naturally. You can even do a nice injectable FSH with an HCG trigger and timed intercourse. You don't have to jump right into IVF. And if there's a male factor fertility challenge present, you can do an IUI. I used to do the IUIs for the clinic I worked at, but you're washing away all of the seminal fluid and all of the poor swimmers, leaving you with the best swimmers, and then injecting them directly into the uterus, giving them a head start to be there for the egg. But I mean, a lot of women are using Clomid and Letrozole, and these drugs are estradiol inhibiting. Estradiol is needed for good cervical fluid and a nice thick uterine lining, and the growth of the egg. And when you take away the estradiol component or bring it down to a very low point, you're starting out with a deficit. That deficit is not going to behoove a good, healthy cycle. So it's interesting how we manipulate to watch women fail so that they go on to the bigger, bolder cycles like IVF.
Mm-hmm.
It's an industry. It's a $20 billion industry.
Yeah, it's a mega moneymaker industry for sure.
Mega.
Mm-hmm. And it does sadden me because those of us who grew up in the 80s and 90s, and I guess also early 2000s, well, I think even younger women today still, we most likely were not taught about our cycles in our teens and didn't know much about them in our 20s, and potentially arrived to an age in which we're ready to have children, and we're actually at an age where we're in between our fertile years and our menopausal years. It's, more and more women are wanting to become pregnant at an age where their body is actually ready for a new rite of passage, like ready for moving towards the change that will eventually be menopause. So women also always ask me all the time, like, till what age can you have a baby? And I'm saying, I don't know. I mean, it depends on, are you still ovulating? I follow this really beautiful woman. She's big in the primitive skills world, and she got pregnant naturally at age 47. She was still ovulating, very healthy had a vaginal birth. So that is possible. I would say her case potentially is the anomaly for most modern women, but I don't know
It
what you're,
is.
yeah.
It is. No, it's great though. It's great.
Espero que estés disfrutando mucho esta entrevista. Estoy contenta de poder ofrecértela y también te quiero invitar a mirar la página de inscripción para mi curso Preparación para la Concepción. Es un curso grande y bonito y completo y justamente ahora en 2025 estamos ofreciendo solo un curso. Dura 6 meses, de abril hasta septiembre de 2025. Y es la última vez que vamos a ofrecer este curso tan grande, así tan completo de 6 meses. Entonces, comenta curso abajo. También en la descripción del video voy a poner el link de la página de inscripción y puedes investigar más sobre este tema tan importante. Es importante para la humanidad, no solo para parejas que quieren concebir, sino para toda la humanidad, para cualquier persona que quiere optimizar su salud y también aprender información para pasar a los jóvenes, a la gente joven que van a formar la siguiente generación, ¿no? Bueno, muchas gracias y seguimos con la entrevista.
So thinking about a woman's age and how her eggs age with her, you have to think about what you've done in your life to maybe create a good, healthy environment for your eggs. So if you were a smoker as a teenager and drank a lot of alcohol in your past, that certainly is declining the age or the age, yes, of your eggs, and they start to die. But women that tend to live a more healthy lifestyle, they can get pregnant into their later 40s. I've seen it. Women that have frozen their eggs as a younger woman, well, you can get pregnant at 50, 55. If you're not married and you have frozen eggs and then you make embryos out of those eggs and then have the eggs or the embryos transferred, you can have a baby pretty much at any age if you have a normally functioning uterus. But a natural conception can be honed in upon by turning the light switch back on. And what I mean is when we haven't had a baby in many, many years and the light switch is turned off from the belly button to the pubic bone, I go in there and I manipulate everything and start waking it all up. And it's like switching, just going in and boop, switching on a light switch to shine a light on that space again so that your ovaries can start hearing the signal from the pituitary gland to make estrogen. And that's exactly what needs to happen when honing in on creating a good follicle for ovulation. We can also use something that's so beautiful, and it's a bioidentical hormone just to kind of support you in your follicular phase until ovulation occurs. And just that little extra added bit of estrogen is key too. And it's a natural estrogen. So there are a few things we can do later in life. And certainly now I'm seeing women that are 39, 40, 41, 42, 43, 45, and they're wondering, can I have a baby? And the answer is you probably can, but we need to get all of the juices flowing in that area again.
So it definitely makes sense to me that we need to touch the organs to create more flow and to create more movement, blood flow, etc. Do you find that a large percentage of women have uteruses that are out of place? Like out of place, would you say that?
That's a great question. There are, let me just talk about the positioning of the uterus. If this is the uterus and this is the abdomen, you can have a midline position. Let me use this hand. This will be easier. You have a midline position. You could have an anteverted anteflexion. So that would be anteverted anteflexion, midline, and then it would be retroflexed and retroverted. So these are not abnormal positions. These would be positions that are anatomically normal for you. So when I go in there and I manipulate, all I want to feel is movement from whatever the position of your uterus is. Now, if your uterus is fixed in position because you've had a prior C-section and there's scar tissue there and everything is kind of glued down into space, into that space, because if this is the bladder and this is the uterus, the incision is being made along the lower uterine segment to open and take the baby out. And then you bring everything back together, and the bladder and the uterus are now not independently functioning. They're glued together, which disallows good blood flow to the uterus. And so I get in there and I really manipulate the two organs to kind of pull them apart. And women are like, oh my gosh, what did you do? I feel such a sense of freedom in my pelvis. This is amazing. And it's honestly, Katie, so simple. It's so simple. And every OBGYN should be referring women post C-section for this kind of work. And here I am, the midwife that had 2 C-sections myself. I had a breech baby for my first baby. Claire was breech. She wasn't moving. 39 weeks and 6 days. My midwife is like, she's breech. And there was no turning her. And I had my water birth pool set up at home with all the supplies. I was so bummed. And then with my second, I was 41, and they were treating me like I was, oh, you're so elderly. And I'm like, yeah, whatever. But my water broke on its own at 38 weeks, and I labored for 16 hours to try and get my son out. And he never went past 0 station. He was always very, very high in my pelvis. And so I felt like we needed to take him, and I'm glad we did, because he had a double nuchal cord around his neck. And then it was a short cord, so he wasn't going to come down. But again, that's where the spidey sense comes in. But anyway, yeah, I mean, we just got to get the light switch turned back on to the area. It's important.
Just a little anecdote about scar tissue. My mom, so we're 3 sisters. My older sister was a C-section. I was a C-section. And then when my mom was pregnant with my baby sister, who actually just had a baby 2 weeks ago, but when my mom,
Congratulations.
thank you. When she was pregnant with my baby sister, the scar tissue from her previous 2 C-sections had grown around her intestines and created an intestinal blockage. And she had to have abdominal surgery with my sister in her uterus to unblock her intestines because of the scar tissue. Isn't that wild?
Yeah, it is, isn't it?
I know. And so these issues, now her case was really extreme, but what you're speaking to about, whoa, scar tissue changes the mechanics of the body and can create adhesions between organs that are not supposed to be there, and that inhibits blood flow. So
100% it does.
what does scar tissue feel like to the fingers?
Ropey.
Okay.
It feels ropey. It feels gritty. It feels connective, as in it's not allowing for anything else around it to move. So I'll go in. I don't get rid of scar tissue. We can't do that. We soften it to allow movement. The only way to get rid of scar tissue is to surgically go in and remove it, but that creates more scar tissue. So, I mean, what's the point?
Yeah, anytime you make a cut, you're going to create scar tissue. Wow. So, okay. If a woman was listening to us and, for example, she's had a C-section and she doesn't necessarily know a practitioner that could do any kind of visceral manipulation on her scar tissue,
Yeah.
maybe she would want to know, is there any danger to her doing self-exploration and trying to feel in her abdomen for the ropey tissue that you're talking about? Just
Not
I
at
mean,
all.
yeah, okay.
Go for it.
Yeah.
Go for it. I mean, I have a pretty trained hand at this point. But if you want to just go in and work on yourself and use your intuition as to where you need to be going, I think that's a great idea.
I've heard some women speak about castor oil in relationship to scar tissue work. Do you have thoughts on castor oil in particular?
Are you talking about castor oil packs or applying castor oil directly to the scar and working it?
Either.
Okay. Yeah, I love castor oil. I think it's it has a great drawing effect. I think I think it's definitely a valid thing to be considered.
Okay. Awesome. You mentioned bioidentical hormone therapy. I wonder what your thoughts are. I have been involved in the Dr. Ray Peat kind of pro-metabolic space, and a lot of people in that space speak to the dangers of estrogen and much more promote the use of bioidentical progesterone because so many women are deficient, especially if they've taken the pill and didn't ovulate for years, also because we're stressed, also because for other reasons they might not be ovulating, and because we live in such a estrogenic world. So so people in that world tend to paint the picture of like all estrogen is dangerous and only progesterone would be safe. And I guess you potentially might work differently and say, no, there is potential for supplementation both on the estrogen side and the progesterone side.
Yeah, I totally disagree. I think there's a time and place for both. And thinking that bioidentical estrogen versus ethinyl estradiol, which is the synthetic estrogen, is going to give you the same result is not an apples to apples comparison. Using a bioidentical estrogen is necessary in some cases and can give a beautiful result with no long-term side effects. So they're probably referencing the Women's Health Initiative study that was released, I believe it was in 2006, talking about progestin and estradiol, ethinyl estradiol being given to women, being cancer causers, and not giving, that was not a study done on bioidenticals. It was a study done on synthetically created hormones. So you can't, there is no evidence to support that using bioidentical estrogen causes any kind of side effects like cancer, because it's human identical to what you make.
Right.
It's an exogenous source, but it's human identical to what you make. And if that were true, Katie, giving all of the estrogen that these reproductive endocrinology doctors give, because they are using a bioidentical estrogen. They're not using ethinyl estradiol unless they're using an oral contraceptive. They do use progestin, not in medically assisted cycles like IVF, but if they're using progestin in the form of Provera to force a cycle to start for a woman that might be anovulation or amenorrhea, they use Provera, which is the synthetic progestin, and it's garbage. It's just absolute junk. So what I'm trying to say is we use bioidentical estrogen in reproductive medicine, in gynecology, and there's never been a study that shows that there's a side effect that would be cancerous.
That's good to know. I have trouble understanding why a synthetic version of any hormone would be used. For example, a woman contacted me, her son was born with, I can't remember the name, it was like it's where, so the opening hub of his urethra was at the base and not the tip of his penis.
Uh-huh.
And it's not something that runs in her family at all. Then it turns out that the doctor had prescribed her, she had previous miscarriages, so she was prescribed 400 milligrams of synthetic progesterone and was taking that vaginally up until she realized she was pregnant. At 12 weeks she stopped. But then I looked at the literature too. There's a lot of literature that says that is the genital deformations are associated with the use of synthetic,
That's
not
right.
synthetic progesterone. And I thought to myself, oh my goodness, I don't understand if it's obvious in the medical literature that synthetic hormone would cause genital deformations, then why wouldn't they use bioidentical? I don't understand.
Well, there's a lot of contradictions, I should say, between using bioidentical and the synthetic hormones, because they want FDA approval for what they're using. And while I understand that it's a liability for them, it's still something that they're most comfortable with because it can be prescribed.
Okay. Wow. It's so fascinating.
And if
So,
you don't have, I'm sorry, if you don't have knowledge about how to use bioidentical hormones, then you're probably not going to use them because it takes a lot of education to be able to use bioidenticals appropriately. And most of these gynecologists, and bless them, they don't know how to use anything but what's in their wheelhouse. So it's a learning curve, right? And it takes time to be able to utilize something that you're not well versed in. And when you think about what an OBGYN does, they're delivering babies, they're doing surgeries, and then they're seeing patients in the office. And that's a lot. That's a lot. So maybe they just want to stick with what's in their wheelhouse and send those patients to see someone like me. So I think that's where integrating here in the future is going to be key, where, hey, I don't do what you do and you don't do what I do, and I'm not going to step on your toes. I'll send your patient right back to you, but we can work together for the greater outcome of the patient. It's not about me and it's not about you.
right,
But
right.
there's a lot of territorial ego present in medicine, which is unfortunate.
Yeah, it's unfortunate because the one who suffers is the patient. But
Exactly.
so going back to the test that you ordered at the beginning, the full thyroid panel,
Mhm.
I think thyroid issues are just so common. Is that your clinical experience as well? That you just,
Very,
yeah. And
very.
is the route when you identify through that full thyroid panel, when you identify low thyroid function, um, do you have thoughts on medication, for example, Armor versus Synthroid versus maybe no medication, maybe dietary adjustments, lifestyle changes? I realize every case is different, but I wanted to touch on the thyroid because it just is so prevalent that we have underfunctioning thyroids.
Yeah. So subclinical thyroidisms, clinical thyroidisms, Graves, Hashimoto's, like there's a time and place to use medication, and I'm all about full spectrum thyroid therapy like NP and Armor, Westhroid, Naturethroid. Those are full spectrum T1, 2, 3, and 4. If a medical doctor is not familiar with how to use those medications, we can use a brand Synthroid and brand Cytomel to get a better balance for a woman. If a woman is trying to get pregnant and her thyroid is off just a little, that's good enough birth control for her body. So, like I said before, we want to make sure that the thyroid is spot on. And of course, diet and lifestyle is huge. It's a huge piece. Most women that come to see me are already doing their due diligence from that perspective. But others are not. And what I simply ask them to do is follow like a Whole30 plan. I think that that's a good one. It's all whole foods, and it's not, I mean, that is gluten-free and sugar-free. And if they can do that and maybe make some modifications to suit their lifestyle and not make it so difficult that they're going to be non-compliant, I think that that's a good start. If they come in and they're like, what do I do? And I say, gluten-free, dairy-free, that's really, really hard to do for some people. It's really hard to do for a lot of people, actually. I don't want them to be so non-compliant and think I'm like giving them so much that they need to do off the bat to make them feel like I can't work with her. It's too much. It's too much. I just cannot work with her. So I want to make it simple. Whole30, you can buy the book, you can go to Pinterest and get the shopping list. Keep it simple. All foods under 5 ingredients. If you can do it, if you want to eat a little bread, you make it yourself, that kind of thing. People are really compliant because you know what? I've really built up a good track record for my practice, and people are wanting to listen to what I have to say. And I only had my 2 babies because of my work too. So if I need to be an example for somebody, I'm happy to be that. But that's the truth. And I love this work. I love serving, and I don't want to make somebody feel like my expectations are going to be too outlandish or out of touch for them.
In your own journey with endometriosis, did you end up having surgery?
I did. I've had 3 surgeries.
Wow. Wow.
Yeah, it was very egregious. I had endometriomas each time that needed to be removed because they were large and leaking fluid into my pelvis. And I'd be driving and feel like I needed to pass out because the pain was so bad.
Wow. And so there was never a real idea about why. Endometriosis is just such a mystery.
Nobody knows why. Nobody knows why it happens. There's no known cause. But I was diagnosed when I was 26. And so I had a surgery then. I had a surgery when I was 31. And then I had a surgery at 34. And then I had my students work on me. And the next cycle we conceived. And we had already been married for a year. And no babies. And so that was the first time in my life I'd been pregnant at 35. And I did manage to have 7 pregnancies, 5 losses. And so the 3rd was my daughter and the 7th was my son. Okay. And yeah, I did everything in my tool bag that I knew to use. And so with my case being more advanced, I feel like that really propelled me forward to help other women.
Yeah, stage 4 is incredible. I mean, that's very, very, very serious.
Oh yeah, it's all over my bowels. It's everywhere.
Wow, but it still is, or?
Oh yeah, I mean, it doesn't go away. Just because you have a laparoscopy to clean it up doesn't mean it goes away. I fully believe that it's on my stomach, it's on my diaphragm. I have a feeling it's up in my brain. And if you look at, and in my sinuses, if you look at the studies, it shows that endometriosis creeps up to those organs. It's so aggressive.
Wow.
I mean, I get sometimes like not like recently, because I'm 50 now. So it maybe in the last, like in my 40s, I would get really bad headaches. And since I was a kid, when I was 10 years old, I would get terrible bloody noses with giant clots coming out of my nose. And I hadn't gotten a period yet. But for a young girl, like I think that I was showing signs back then. And I almost equate it as like a period coming out of my nose with hormonal changes, as opposed to getting a period from my uterus. It very interesting to note.
Yeah, I wonder when the first documented case of endometriosis occurred. I don't know. Like, I guess my inquiry is it something of modernity? Is it a modern affliction, or is it older than that, and then we just didn't know what it was, maybe 200 years ago. It was just like someone was in really horrible pain and didn't have an explanation for it. I don't know. It's just so fascinating to me.
It is.
Because
It's a fascinating disease, that's for sure. I don't know when the first documented case of endometriosis was seen, but yeah, it's not something new. It's been going on for a long time. I also remember when I was little growing up that my aunt had endometriosis. She's now almost 70, and she had a hard time getting pregnant, and they gave her a drug called Lupron. Lupron puts the body into a temporary state of menopause. So she was only able to have one child, and she had many, many miscarriages. I'll never forget that. But she had endometriosis too.
Yeah.
And so, yeah, I mean, it's nothing new. It's a crazy disease.
Wow.
Yeah.
Um, and then what about women who come to you with PCOS? That one in particular is really challenging because, as you mentioned before, and as we know, the cycles tend to be really long. And so there's, I know a lot of women who start to track their cycles. They want to do the symptothermal method. They want to, they want to start taking their temperatures and tracking their cycles. But if you have PCOS, potentially it there's not a rhythm to it, and it can be a challenge.
It's a huge challenge, even for me. I have to look at, so I do cycle charting with my clients. And when I finish the 6 sessions of Mercier therapy with them, they're 6 1-hour treatment sessions once a week for 6 weeks. I can even wrap it up sooner than that. And I do for women that come from out of state or out of the country to see me. I'll do 90 minutes of treatment for 4 days back to back in a row to get 6 hours done. I like to cycle journal then with my clients after they finish with me with the sessions, and I ask them to at least document 3 cycles and then come back in and meet with me so we can go over the data that they've collected. And sometimes I'll make changes to the plan that I originally made according to what I'm seeing in their cycle. PCOS is a big bad bear, just like endometriosis. But I would say PCOS is, I think, a little more challenging.
Mm-hmm. Do
I
you find,
do.
yeah, the cycles are just can be so long and so erratic that it's hard. It's hard.
Yeah, it is.
Mm. Do you find that you go towards the dietary path? I know you mentioned Whole30, which is lots of meat, lots of non-starchy vegetables. I guess do you kind of use that approach for everybody? So potentially, like maybe some woman has the more thyroid issues, somebody's got the PCOS, someone's got endometriosis. Would that be like, in terms of dietary suggestions, would that be your starting point for all of
It
them?
is. Whoops. There you go. Sorry about that. Yes. Sorry about that. Yes, it would be. It would be the place that I start with every woman. I really like the Whole30 plan. I think it's well-rounded. Again, if they want to add in some bread that they've made on their own, or, we're getting so creative with different things that we can make on our own as far as sweets are concerned, that sort of thing. It can be modified. But yeah, that's where I start because I think eating, proteins and vegetables, like that's pretty achievable. Like that's pretty decently easy for most people to do.
Yeah, more protein, more vegetables, and then sufficient animal fats for hormone production
That's
as well.
right. That's right. Butter. Yeah, absolutely. Butter, avocado oil. And a lot of berries too. I think berries are really important.
Um, it is easier to, I imagine, it's easier to treat someone who is coming in with some bad habits that, so there's a lot to suggest to them. It's a little bit harder to have patients who maybe are already doing all the right things and still are having problems, because I've talked to other doctors who say that. I was listening to a physician speak, and she lives in the Bay Area, and she said, I have the most educated patient population in the world. So it's not like she can just be like, well, stop drinking Coke and you should eat butter, because for
Right, right,
people.
right, right.
So, and I guess that also, that kind of goes into the fertility journey is a spiritual journey as well. Like that your, it's a sacred contract between you and baby and husband. And
Right,
so there are not everything can be fixed with bioidentical hormones and food.
right. I agree. Oh yeah, I've been seeing a lot of relational issues too lately between husband and wife. I think the weight of this world is getting to people. Don't
Mm.
you think, Katie?
Oh yeah, absolutely. I think that there's like a general in the last couple of years, the general sense of dis dis-ease, like uneasiness, and um so much uncertainty about the future, and kind of a like a heightened sense of anxiety collectively. And I do think that that impacts people for sure.
Big
Um,
time. And the use of technology too. I mean, we're constantly on technology, constantly. And I'm not talking about like watching a movie, listening to podcasts. I'm talking about when we're constantly scrolling, social media. This can really do a number on us.
right. It's bad for our eyes, it's bad for our circadian rhythm, and it's also just bad. It's bad for our attention span, and it's bad for our mental health, because what you see is just the snapshot of someone's life, and you
Right.
don't. Yeah, humanity is definitely headed down towards a dystopian future. Absolutely. But it's what we spoke about before we started the call. We there is such a sacredness to biological design, and that's ultimately, despite all of the promises of modern medicine with IVF and all these things, um, we can obviously see, because you provided us with the evidence, that like a reverence towards that sacred biological design is ultimately the most successful and fulfilling path.
Right.
Mm. So, um, let me see. I want to see if I had any more uh, questions. I think quite a few women will be interested in receiving the kind of visceral manipulation that Mercier therapy offers. I'm interested. I have not received Mercier therapy, but I have received our Vigo massage, so Mayan abdominal massage, it's very lovely to be touched by someone who has knowledgeable hands. So maybe where should women go to potentially network with a practitioner who could do this sort of visceral manipulation on them?
Sure. Merciertherapy.com. There's a provider list there, and you can go and see if there's someone in your area. And if there isn't, you're always welcome to come and work with me directly. I'm in Geneva, Illinois, and a lot of women use that option. So if that's something on your heart and you want to try it, you just let us know. But the provider list is extensive. We're in 22 different countries.
Wow,
So hopefully you'll find somebody in your area that you can work with.
that's wonderful. And are you still actively training practitioners?
Oh yeah. Yep. 4 times a year I have a training. It's usually March, May, August, October.
Okay. That training is open to people who or women who are licensed to touch.
Licensed to touch. I do have women that come and train with me that are not licensed to touch, and they do great. They're like Pilates instructors, childbirth educators, doulas. I mean, those people are not licensed yoga instructors, but they do a great job in their work. And because this is not licensable, like it's not massage, it's body work.
Right.
So yeah, I mean, I'm happy to talk with professionals that want to be trained that are not licensed. And that would be, them working at their own discretion in their own jurisdictions, taking the full liability if, something should go wrong. But from my lips to God's ears, there's never been an issue with anybody.
That is so good to know, because I would love to take your training.
You should come train with me.
Oh my goodness. I just feel like your knowledge is so important. We must learn what you know. Like we must learn.
Well, thank you. I actually just wrote and released a women's wellness and reproductive health fellowship. And so that's out there too. So you could do the fellowship course, and that would be mercierwhf.com.
Okay, awesome. Mercier WHF. Beautiful.
Yeah.
Cool. Well, thank you so much, Dr. Do women call you Dr. Jenny? You prefer Dr.
Yeah,
Jenny?
that's perfect.
Dr. Jenny, thank you so much for your time. I will include the links we talked about in the video below, and I will also include links to your books, to your documentary, and then I know you have a new documentary coming out soon. So those and the documentary that you have already published is subtitled in Spanish. So that's going to be like very, very important, I think, for my audience to watch, because it is so impactful to hear firsthand stories from couples who kept receiving the story that they were not going to have a baby, and then they were able.
Sure. Absolutely. And the film can be purchased on my expectamiracle.life website. Expectamiracle.life website. I had my film with a worldwide sales and distribution company for 5 years, and I actually just took over my film again last year. It's not on Amazon, it's on my website, and that's the only place you can access it. The new movie we will put up on Amazon for a while.
Awesome. Thank you so much. I really appreciate your work for women and for humanity. It's so important.
Thank you. Yes, perfect. I'm glad we could meet up and have a little talk this morning.
Thank you so much, Dr. Jenny.
You're welcome. Let us know when the episode is out so